Thanks very much. I do want to thank the organizers for permitting me to be part of such an august group of investigators. It really is a pleasure. I've learned quite a bit and enjoyed hearing what everybody's had to say. As an interventional cardiologist, and I am a clinician by trade, I spend my days really destroying the endothelium and my nights thinking about how best to improve it. So I think I look forward to discussing this, and I do hope to engage you in some open discussion, because the topics that have been brought up so far tonight and will be brought up again in the ensuing talks are really pertinent to the thoughts that we've been exploring with EECP, and continuing this evolution of thinking will be important for us, I think. As has been clearly pointed out, endothelial balance, endothelial function is central to our well-being. Normal endothelial function involves a balance between factors, good factors being nitric oxide, prostaglandins, bad factors. Simplistically, again, I'm an interventional cardiologist, endothelins and angiotensin. But that leads to vasodilatation, atheroprotective properties that are critical for us. When endothelium is out of balance, when there's endothelial dysfunction, of course, there's relatively less good and relatively more bad. You could vasoconstriction and an atherogenic process. And I was very pleased to hear about the endothelial repair mechanism being discussed, because depletion of EPCs are an intrinsic part of endothelial dysfunction, and more generally, as I want to point out later in the talk, hemopoietic precursor cells are really central to this process of endothelial dysfunction, restoring endothelial balance, endothelial function, and may have implications for how external counterpulsation actually works. Endothelial dysfunction, of course, is associated with risk factors and a disease state. The more risk factors you have, as was pointed out nicely, the worse your endothelial function tends to be. See that you can fairly delineate a linear relationship between the number of risk factors and endothelial function measured invasively. And in fact, endothelial dysfunction is associated with myocardial ischemia. So if you measure exercise thallium tests, even in the absence of obstructive coronary disease, you can see that in patients with abnormal functional tests, their responsiveness to acetylcholine is impaired. They have impaired endothelial function, even in the absence of coronary disease. And so this is a very early marker, as was pointed out earlier, of endothelial or of atherosclerotic disease and of the risk state. It really leads to that whole concept of a vulnerable patient who's got a global process that's deranged and endothelial dysfunction. Our group looked carefully at long-term outcomes. So I've shown you that risk factors are associated with poor endothelial function. Endothelial function or dysfunction can be associated with ischemia and other markers of bad outcome, but actually endothelial dysfunction is associated with bad outcome itself, as has been pointed out in earlier talks. And so by measuring endothelial function peripherally, in this case, with the EndoPatch or peripheral arterial tonometry, our group showed that patients with endothelial dysfunction had worse long-term outcome over a period of 5 to 7 years compared to people with normal endothelial function. And this is not due just to increased hospitalization, but this is due primarily to mortality. So it's a very profound marker of adverse events. Shear stress, it turns out, is atheroprotective. It hasn't really been brought up as much today, but shear stress is a very potent effector of vascular health. And so by promoting shear stress in the right dose, perhaps we can have a beneficial effect on endothelial function. And so that got us thinking about how this external counterpulsation that Özlem showed you has great effects on angina scores and quality of life and maybe prognosis, but maybe endothelial function has a role in how we can put that together and how EECP works. And so, in fact, we looked at all of the effects that EECP has. EECP has a global effect on flow and shear stresses throughout the body. So as Özlem said, there's diastolic augmentation, systolic unloading, just like a balloon pump. So there's an increase in cardiac output, and you can demonstrate increased flow, pulsatile flow, throughout the vascular tree in all major vascular distributions. This has been demonstrated in the animal model. In pigs treated with EECP, you can see their shear forces pre and during EECP. There's a fairly dramatic 100% really doubling of shear forces in the intact animal. And this has a variety of effects, and in this particular case, they measured ENOS levels in those pigs, and it was positively affected in both controls and in patients, and in pigs who were in a disease state. In the pigs that were in a disease state that did not have ECP, there was no benefit or no change over time in the ENOS levels or an intima media thickness ratio. Other actors associated with external counterpulsation and vascular health include nitric oxide and endothelium levels. These were actually measured, and as you can see on this graph, because ECP is a prolonged course, it's a 7-week course of therapy, we can measure effects over time, and here you see a dose-dependent relationship between the good actor, the peripheral circulating nitric oxide levels, a dose-dependent decrease in endothelium levels that persists over the treatment time out to 7 weeks, and then a gradual reduction back towards normal or back towards the baseline state after the cessation of therapy. This has also been shown, interestingly, with angiotensin and other factors. We looked at this in the intact human then in a different way. We wanted to measure peripheral arterial tonometry, or a measure of endothelial function. I already showed you that this does have an implication for prognosis. It has an implication for symptoms and ischemic burden. And so what we did is we developed a protocol by which we put a patient at rest, inflated a blood pressure cuff for 5 minutes, deflated the cuff, and measured their peripheral tonometry for 10 minutes. You see you get a tracing much like this. The tonometry resistance index, or the RPH index, is the ratio of the post-occlusion pressure divided by the pre-occlusion pressure. So you get a ratio. And in fact, that ratio has been looked at. Somebody asked a question about whether this has been established in the disease state versus the healthy state. And there is at least a ratio for the peripheral arterial tonometry for health versus disease state. So in patients with invasively measured coronary endothelial levels that are abnormal, so people who have coronary endothelial dysfunction, their tonometry index is roughly 1.2 on average, whereas in normal cases it's closer to 1.8 or 2. So there's a fairly dramatic and measurable difference in the disease state versus the normals. We used that information in our patients undergoing ECP. So we took 25 patients, measured measured on 3 separate occasions during treatment, the first day, middle day, and the end day, their peripheral tonometry both before treatment and after treatment. What we found, interestingly, was that in yellow, the pre-treatment endothelial measurement was the same on each of those days. Not sure why that was. It surprised us. We had hoped it would look better. But what we did find is that at the end of treatment, their peripheral arterial tonometry measurements actually improved more towards a normal level. Remember, again, that endothelial dysfunction level, about 1.2. So they exceeded that. Their endothelial function improved. We also verified that they did not have a change in their nitroglycerin responsiveness and other factors that may play a role. And so this seemed to be a real endothelial-dependent endothelial function effect of ECP. And when we measured again out at a month after treatment, so they've had 7 weeks of therapy, then we measured a month out, surprisingly, or maybe not surprisingly, their resting endothelial function, by and large, was improved. So again, to not a dramatically normal level, but it was improved from baseline, and that was statistically significant. I think a powerful confirmation of this effect is that this kind of change was only seen in those people who had symptomatic benefit. So in the 75% of patients who felt symptomatically better after a course of therapy, they had improved endothelial function, whereas those patients who did not have that clinical benefit did not show that change in endothelial function before and at the end of the treatment, whether you measured it by quality of life, nitrate scores, or the DAISY quality of life score. Another question was, has it been shown, is there an association between precursor cell measurements and the EECP? And in fact, we looked at that as well. So prior studies in our group had looked at both hematopoietic precursor cell levels, and you can see all of the types there, as well as the EPC, the putative EPC groups. And in normals, you can see on the left of this graph, the normals had those levels circulating peripherally at baseline. People with measured coronary endothelial dysfunction had dramatically reduced, as was pointed out earlier, dramatically reduced levels of these circulating progenitors. The hematopoietic, the HPCs, I'll say, were reduced. The EPCs tended to be about the same in both groups in our population. This is an old population, so some of this is related to age and other risk factors, but the coronary endothelial dysfunction group definitely had decreased levels of these things. Now, when we looked in our groups undergoing EECP, what we found is that the EPC levels didn't change very much, but actually the HPC levels increased again in a dose-dependent fashion during the time of therapy, suggesting anyway that there is some modulatory effect. Whether this is healthful or not is a little bit unclear, but there is a response. So whether this is related to preconditioning or just modulation of the endothelial function, humoral processes is unclear, but these things are going on. In the intact human, this has been investigated in a variety of ways, and I think what we're going to move on towards, again, being a clinician, the thing that interests us is the diastolic function, and diastolic function has been modulated or shown to be modulated by ECP as well, possibly all within this realm of endothelial function, humoral or cellular components and changes during the course of therapy. And this graph just shows that diastolic function actually did improve after a course of therapy. So there are a variety of clinically apparent interventions that improve endothelial function, primary of which actually is exercise. And as a pulsatile sort of diastolic augmenting process, ECP is really similar, I think, to exercise. And so as a passive means of exercise, I think ECP can be put in this group of interventions that does have a role in modulating endothelial function. And so as a bottom line, I'd like to say that optimal medical therapy and risk factor modification are essential to improve endothelial function. I didn't really go over any of that, but it's true. And ECP actually provides safe, effective, durable symptom relief, as Özlem showed, and is associated with improved quality of life and vascular health. And it's a potential pathway to improve prognosis, I think, and of course that's a stretch for us in science, but the markers that are modulated are associated with better outcomes, and so it modulates it. Maybe it improves prognosis via plaque modification, vascular function, and myocardial performance effects, as I talked about in my discussion. And that's all I've got. Thanks.